First of all, I think I will leave this part till the end, and then I will just go over one of the topics, one of like an important topic, and one of the rare topics in oncology, which is considered as an oncological emergency. And I thought it's important to know about tumor lysis syndrome because frequently we admit patients who are gonna get started on chemotherapy, so we should be aware of the side effects of chemotherapy, including tumor lysis syndrome and adequate management of tumor lysis syndrome. So tumor lysis syndrome is basically, as I said, one of the oncological emergencies. Usually and more frequently, you see tumor lysis syndrome when you initiate chemotherapy for patients with high-grade lymphomas. Usually high-grade lymphomas are known to be at higher risk of tumor lysis syndrome because of the tumor burden and the high proliferative rate of the cancer, particularly in patients with Burkitt's lymphoma and also ALL. However, it was reported that it can happen spontaneously in patients with tumors, as we said, which have high proliferative rate and high tumor burden. And because we said this is an oncological emergency, it's very lethal. You are talking about a lot of electrolytes, which can lead to multi-organ system failure. So it's very important to know who are the patients who are at high risk for developing tumor lysis syndrome, identify these patients, admit them to the hospital at the time of initiation of chemotherapy, and start early preventive therapy to prevent the development of tumor lysis syndrome. So etiology and risk factors. So as we said, tumor lysis syndrome is more common at the timing of initiation of cytotoxic chemotherapy. It's more common in hematological malignancies rather than solid malignancies. And as you can see here, in this table from up to date, in patients with ALL, the total incidence of tumor lysis syndrome can be up to 47% at the timing of initiation of chemotherapy. In adults, it's about 19%, and in pediatrics, it's higher, it's about 63%. And then you have other hematological malignancies such as ALL, CLL, Hodgkin lymphoma, non-Hodgkin lymphoma, multiple myeloma. It's less likely to be on solid tumors rather than in hematological malignancies, and there was some case reports about the occurrence of tumor lysis syndrome in patients with breast cancer. So, but always put in your mind hematological malignancies at a higher risk of tumor lysis syndrome. There also has been some case reports of tumor lysis syndrome, which was precipitated by radiation therapy, usage of dexamethasone, thalidomide, and the usage of newer chemotherapeutic agents such as rituximab and bortezomib. What are the risk factors? So there are some risk factors related to the tumor itself, which puts it at higher risk for developing tumor lysis syndrome, which is high tumor proliferation rate, chemosensitivity of the malignancy, how chemosensitive is the tumor is, and larger tumor burden, which this is the definition that they defined that bulky disease more than 10 centimeter, white cell count more than 50,000, and the pretreatment serum LDH more than 2 times upper normal limit. Presence of organ infiltration or bone marrow involvement are risk factors for tumor lysis syndrome. There are some clinical features in the patient himself which makes him at higher risk for developing tumor lysis syndrome. This includes the persistence of hyperuricemia or hyperphosphatemia prior to starting chemotherapy. There's pre-existing nephropathy or exposure to nephrotoxins, oliguria, or acidic urine, dehydration, volume depletion, or inadequate hydration during treatment. So it's imperative to recognize these before starting chemotherapy and try to reverse these factors as much as we can before starting the chemotherapy. What is the pathogenesis behind tumor lysis syndrome? So what happens exactly that due to the rapid turnover of the cells and at the timing of initiation of chemotherapy, there have like cell lysis occurs, which leads to the release of multiple intracellular anions such as potassium, phosphorus, and a lot of nucleic acids, and in turn, nucleic acids are metabolized to uric acids. So nucleic acids, we have like purine and pyrimidine. Purine catabolism, which I guess was adenine and cytosine, will be transformed to hypoxanthine, and then xanthine, and then uric acid. And it's important to look at this at this graph here, just to remember where does allopurinol acts, which is like a xanthine oxidase inhibitor, and the exogenous urate oxidase, which we're gonna talk about later, which is rasburicase, which stimulates the urate oxidase enzyme. And then when you have these cell lysis and the release of potassium, phosphorus, and the nucleic acid, this in turn leads to hyperkalemia, hyperphosphatemia, with secondary hypophosphatemia, hyperuricemia, as we said, due to the nucleic acid release, and due to the uric acid deposition in the kidneys, this will turn on into like obstructive uropathy and AKI. What is the clinical features? The clinical features usually reflect the underlying metabolic abnormalities or electrolyte abnormalities with hyperkalemia, hyperphosphatemia, and hypocalcemia. So you might see nausea, vomiting, fatigue, lethargy, heart failure, arrhythmias, can lead to seizures, muscle cramps, tetany, and syncope. And usually acute uric acid or calcium phosphate deposition doesn't usually cause like flank pain. However, in some cases, due to the formation of the stones, it can cause flank pain, but it's like uncommon symptom. The signs and symptoms of tumor lysis syndrome can develop within spontaneously or about 72 hours after initiation of chemotherapy. So what's the criteria for the evaluation or the diagnosis of tumor lysis syndrome? There was a certain criteria which was developed by Cairo and Pasha for the lab diagnosis of tumor lysis syndrome. So they developed a criteria for laboratory diagnosis of tumor lysis syndrome and clinical diagnosis of tumor lysis syndrome. So for laboratory diagnosis of tumor lysis syndrome, it requires 2 or more of the following criteria, which is achieved within 24-hour periods, 3 days before or 7 days after the initiation of chemotherapy. So if the uric acid increased 25% from the baseline, or the uric acid is greater than 8 milligrams per deciliter, potassium 25% increase from baseline or greater than 6 milliequivalent per liter, phosphorus 25% increase from baseline or greater than or equal 0.5 milligram per deciliter, and the calcium 25% decrease from the baseline. So remember, it's always a rule of 25. So if it's decrease in the calcium or increase of the uric acid, potassium, or phosphorus, and you get like 2 out of the 4, then you have a lab diagnosis of tumor lysis syndrome. And then clinical diagnosis of tumor lysis syndrome, which is the lab abnormalities mentioned above, plus creatinine more than 1.5 the normal limits, the occurrence of seizures, cardiac arrhythmias, or sudden death, and other origins of or other etiologies of AKI cannot be excluded. So how to manage tumor lysis syndrome? Basically, the management is prevention. The disease is the most important thing is prevention, which is recognizing patients who are at high risk for developing tumor lysis syndrome. As we said, patients with ALL at very high risk, especially patients with Burkitt's lymphoma. These patients should be admitted to the hospital, and in case if they needed transfer to the ICU, they should be transferred to the ICU for close monitoring. Prevention strategies should include hydration, adequate hydration, prophylactic rasburicase in high-risk patients, and hydration plus allopurinol or rasburicase in intermediate-risk patients, and the close monitoring for low-risk patients in hospital settings. So in terms of hydration, the recommendation usually is IV fluid hydration 48 hours before starting chemotherapy and should be continued for 48 hours after the end of chemotherapy. Usually they recommend 3 to 3.5 liters per day and monitoring the urine output to provide adequate hydration. Regarding the management with allopurinol, which is, as we said, if we look here at this graph, allopurinol is an xanthine oxidase inhibitor, so basically it prevents the formation of uric acid. So it effectively decreases the new uric acid formation, and in turn it will decrease the incidence of obstructive uropathy. They recommend initiation of treatment 24 to 48 hours before the start of induction chemotherapy, and they continue usually for 3 to 7 days after the end of chemotherapy until there is normalization of serum uric acid or lab evidence of resolution of tumor lysis syndrome. However, allopurinol has a lot of side effects or limitations to its use. First, because it decreases the uric acid formation, it does not reduce pre-existing serum uric acid. So if you have a patient who already have hyperuricemia, allopurinol is not gonna decrease the serum uric acid level. In this situation, it's better to start the treatment with rasburicase, because rasburicase usually it's a urate oxidase agonist, so it metabolizes uric acid into a more water soluble, and in turn increases the urinary excretion of uric acid. And then allopurinol also, it increases the serum levels of purine, hypotensiine, and dentine. And then xanthine can precipitate in the kidneys and can lead to xanthine crystals in the renal tubules, and in turn it can cause AKI. Also, allopurinol has a higher risk of interaction. It has a lot of interactions with multiple drugs, including cyclophosphamide, methotrexate, loop diuretics, ampicillin, and thiazide. So it's important to look at the interactions before starting allopurinol. And also, it has been associated with hypersensitivity reactions, risk of Stevens-Johnson syndrome. Nothing comes without risk. Regarding rasburicase, so rasburicase is a recombinant urate oxidase enzyme, and basically, as we said, it increases the degradation of uric acid into water-soluble compound called allantoin, and allantoin is more water-soluble, so it will be easily excreted in the urine. And it's recommended as initial management of pediatric and adult patients who are at high risk for tumor lysis syndrome, especially those who have impaired kidney functions or cardiac functions. Doses are generally administered as once daily, although if tumor lysis is massive, you can increase to twice daily. Usually oncology are the ones who are going to be managed dosing. And the recommendation, the therapy for rasburicase, usually 2 days up to 7 days. There is a black box warning about rasburicase. Rasburicase can increase the risk of hemolysis. It can cause hemolytic anemia in patients with G6PD. It also can cause severe methemoglobinemia. So it's important to know if your patient is at high risk for G6PD, is like of certain racial population who is known at high risk for G6PD. It's important to know that. And also there's a black box warning about rasburicase because it has been reported to be cause anaphylaxis. After giving rasburicase, usually the recommendations is monitoring the serum uric acid 4 hours after the administration of the first dose, and then every 6 to 12 hours until the resolution of tumor lysis syndrome. And there is a certain way in the lab that uric acid level should be collected when you are giving rasburicase in order to prevent false negative results. The other option of treatment which I found was febuxostat, which is similar to allopurinol. However, and its use is limited and usually recommended for patients who cannot tolerate allopurinol in a setting where rasburicase is either not available or contraindicated. Urinary alkalization has been used before, but there is no data to support the usage of urinary alkalization to increase uric acid clearance from the kidneys, which by acetazolamide or sodium marker. This was an algorithm up to date how to classify your patients into high risk and low risk. So it depends on the lab test. And then once you diagnose or you are suspecting this is tumor lysis syndrome, if you have 2 abnormal lab results and it's a high risk of malignancy, then you start prophylaxis with hydration, rasburicase, cardiac monitoring with labs every 6 to 8 hours. If you have a laboratory diagnosis of tumor lysis syndrome plus one of the 3 that we mentioned, which can qualify them for clinical tumor lysis syndrome, elevated creatinine, cardiac arrhythmia or seizures, then these patients should be hydrated, rasburicase, cardiac monitoring, or ICU admission with lab test every 4 to 6 hours. And then anything else, one abnormal test, you look at the risk for the tumor itself, for tumor lysis syndrome according to the tumor burden, and you classify them and manage accordingly. Those are my references. Any questions?
Hey, Osama. So I had a quick question. So,
Sure.
I don't know if you've done your heme rotation here, but here then in practice, when someone is started on chemo, do they do the labs as soon as 3 days after or up to a week after routinely?
I have a patient who was admitted with ALL.
Yeah.
And we were checking. She finished the first cycle of chemotherapy while she was in the hospital, so we had to do all of these labs. I think it was every 6 hours. We were doing it every 6 hours because she's at high risk for tumor lysis.
Okay.
Is an answer for you?
Yeah, I guess.
Yeah.
I just that I guess that does, because she's more high risk. But I was just curious if someone, like you said, you hydrate them before and after, and then you could do the allopurinol. But once they get their chemo, do you say get follow-up labs within a few days or a week?
Yeah, you can see them in the clinic when they come to the infusion
Yeah.
center. Usually, like they check their blood work when they come to the infusion center. And as I said, it depends on what tumor are you treating. Are you treating a hematological malignancy? Are you treating a solid malignancy? What is the risk of tumor lysis syndrome?
Okay, thanks.
Just to add more, I've seen patients have labs after it like daily for up to like a week or two after.
Okay, even daily? That's, yeah, okay.
And then a couple of patients were sent to the ED because the oncologist was worried about even like a day or 3 days after chemotherapy.
Yeah, okay.
And then I think it was very nice. I just want to say like one couple of things inpatient to consider for us as IM. Always consult oncology because they have things to add. And then the other thing, when you monitor urine output, it should be hourly. So that might be difficult to be done on the floor. So if your patient needs ICU, do it early. It should be 2 ml per kg or up to 100 ml of urine per hour. And then the other thing, if the patient is not producing it per hour, you should not wait. So either you should consider using diuretics, and you don't use thiazides, you use loop diuretics. And as Osama said earlier, loop diuretics interact with allopurinol. So you need to be careful if the patient is on allopurinol. And if they're still not responding after loop diuretics, especially if they have CHF and they're at, like if they're at high risk for pulmonary edema, and you're just giving them 2 or 3 liters. So that's a thing to consider too. You need to think about dialysis as early as possible. So if you think your patient might need this, especially if there is hyperkalemia, put the quintin early to get dialysis done. And then one more thing is the calcium. I read a couple of things before that if there is hypocalcemia, you don't have to treat it unless it is very severe or if the patient is symptomatic, because you don't want because if you give calcium chloride or calcium gluconate, then you're at high risk of depositing it in the kidney and causing further AKI and worsening the whole situation. So if the patient also has hyperkalemia with EKG changes and you want to give calcium, be cautious. Definitely give it for EKG changes, but you don't have to give it for hypocalcemia itself. And then, does anyone know the difference between calcium chloride and calcium gluconate from interns, maybe?
I think we should have Abdullah answer that question because he loves calcium chloride.
Really?
Yeah, look, he's smiling.
Do you guys know? I've told my interns in my ICU 5 times this information.
Rohan then, right? Abdullah?
Oh, he's off today. He's not.
Oh, he's off. Okay. Shoria, maybe. He was with you, no?
Yes, Shoria was. Priyal, is Shoria around you? Oh yeah, I can see him moving.
Yeah, he is here. Just to add to what Maham was like wondering about, to be honest, in clinical setting, they have that order set, patient gets those labs weekly whenever they come before administering chemo and after that. So it's actually pretty well like in an oncology patient getting chemo, they actually look for it and it's pretty much, covered. But yeah, inpatient side, when we have patients like that, especially in ICU, we need to watch out for that. Okay, Sharia.
I believe, if I remember correctly, calcium chloride contains like 10 times as much calcium than calcium gluconate. So it's more effective and faster as well. Protect the heart.
Yeah, so it contains more calcium, but 10 is too much more than the calcium gluconate.
Yeah.
Calcium.
Okay, that's what Abdullah told him.
3 times. It's 40 ml equivalent in the calcium gluconate and 120 in the calcium chloride. But the main thing to know in the calcium chloride, it shouldn't be given in the peripheral IV because it can cause irritation. So in the ICU, it's always calcium chloride. In codes, it's kind of questionable. Some people still give calcium chloride, but it's irritable to the peripheral IVs.
And it's less volume, I think, the calcium chloride compared to the calcium gluconate. So if you can give it, go ahead and give it. And then the other thing also, in patients who are at high risk for tumor lysis, be careful what kind of medications you start them on. Because some, I think, bisphosphonates like zoledronic acid can precipitate tumor lysis syndrome. So this is something to be cautious about in a patient with a high risk for tumor lysis. Thanks, Osama.
Thank you, Shu. Thank you guys for your addition.
I have a question, Shu.
Yeah.
So I didn't get your point. You say if your patient doesn't produce enough urine, you give loop diuretics, not extra hydration,
Not thiazide diuretics.
not thiazide. But you
Thiazide
give,
causes hyperuricemia, but you continue the IV fluids with the loop diuretics.
I see. Okay.
Thiazide causes hyperglycemia, lipidemia, uric acid, and calcium.
And even loop diuretics was not well studied, so it's not based on like data or algorithms. It's just because you want to maintain the urine output.
Yeah.
Thank you,
Very
guys.
good. Anyone has any comments,
Thank you.
questions? Thank you very much.
Any
Osama.
questions, guys?
Sometimes these patients might have seizures also, so just keep an eye on that because of
Yeah.
these electrolyte issues, but that's the only thing.
Yeah, I remember last time I was on night float, and I don't know if it was Mahmoud or Yasser. We had a patient who has a history of CLL.
It was me.
And yeah, it was Yasser, and she came with a white cell count of 280,000. And we were kind of scared because of the risk of that, because she's at higher risk of tumor lysis syndrome. We tried to reach out to the oncologist on call, but like they called us back after 3 or 4 hours.
Yeah, we ended up starting her, if you remember, on hydroxyurea and rasburicase as well, 4 milligrams. Yeah.
Even Osama doesn't remember Yasser or Mahmoud. He just knows someone Egyptian one.
Some Egyptian was with me, like.
Yeah.
The thing is, also when you start hydroxyurea, you need to usually give something with it, like you did, Yasser, the rasburicase, because hydroxyurea will precipitate
Increase. Yep.
Yeah.
Okay, awesome. Thank you guys. We'll log off, and then the heme onc. It's up to you, Yasser, if you guys want to stay